We started these master classes with understanding of approach to acute chest pain. Then we continued with ST segment elevation myocardial infarction. Following which we did the class on non-ST segment elevation acute coronary syndromes on Tuesday. Today we are going to take up the third entity in that series. This is called the unstable angina, usually designated as UA. Unstable angina, deconstructing the ischemic threshold. Again, it runs in three parts. The first part is on pathophysiology, clinical presentation, conceptual understanding, and high sensitivity era. So you are the target audience, postgraduates of internal medicine. We are using the guideline framework of 2025 American College of Cardiology, American Heart Association, Scandinavian Heart Association, and European Society of Cardiology guidelines. Whatever I am teaching you is right from the pen, very current knowledge. So we have to reconstruct the clinical and mental model of acute coronary syndromes by linking macroscopic phenotypes to microvascular cellular pathology. That is the understanding. Now let us try and see. You all know the backbone of understanding and evaluation of acute coronary syndromes is dash what? Is HS high sensitivity troponin. Not the ordinary troponin, which you used to do earlier. Maybe in your hospital you may still do troponin. Forget about it. Ask the lab people to start doing high sensitivity troponin. This HS troponin has changed the scenario. This is the biomarker detection threshold. In stable angina, it will be very not much elevated. In unstable angina, it will be elevated, all right, but not to the extent of 1 hour delta and all that. Now, in NSTMI, in STMI, the elevations are profound. So we are basing mostly one important parameter is the biomarker. What is the biomarker? High sensitivity troponin test. Now, historically, I used to teach the same topic around 10 years back. Acute chest pain, ischemic symptoms will be there. There were no standard biomarkers around 15 years ago, and served as a broad clinical basket or bucket. Every intermediary presentation which is not acute infarction, which is not angina, is dumped into that basket. We used to call it as unstable angina because there were no biomarkers in those days and we are not able to classify them. Heavily dependent upon the subjective history of the patient and the ECG changes. Suppose somebody has got symptoms, ECG is not showing any changes, there is no way to say whether it is unstable angina or STMI or ST segment, non-ST segment elevation because the absence of biomarkers. Now, you are in an era of modern reality, 2025 guidelines and 2023 European Society guidelines. Unstable angina is a clinical syndrome of myocardial ischemia, strictly lacking sustained ST elevation or ST depression, which we see in the two other categories, and or high sensitivity biochemical evidence of necrosis in the form of HS troponin is not there. A patient has symptoms, he does not have ECG changes to qualify him for ST segment elevation or NSTMI, and he doesn't have the biomarkers, but the symptoms are there. Such a person comes into unstable angina, and this is a shrinking diagnosis. After excluding non-cardiac chest pain, STMI, NSTMI, without much of elevation of the troponin, HS troponin, and without typical ECG changes, a few patients still remain in this basket. They are the unstable angina. So there is a heavy reliance on high sensitivity cardiac troponin. You should understand these two scenarios. Scenario on the left side is a thick capped fibroathyrome. You see here, this is the fibroathyrome. Okay, There is a fibrous cap, very thick cap. This is the erythematous deposit. If the cap is thick, it won't rupture easily. It grows and grows and grows. The vessel will be narrowed and there will be a flow limiting obstruction. You understand, there is no rupture occurring. The cap is thick. This is called the thick capped fibroethyroma, where there is a progressive narrowing of the lumen of the blood vessel. This is called the flow limiting narrowing. Whereas in other patient, the very thin cap, it ruptured, it thrown open the lipid-rich material to the bloodstream, platelets are activated, white clot is formed, and then there will be a havoc there and thrombosis occurs. This is the plaque disruption. Plaque progressive obstruction and narrow lumening, and the very stable fibrous cap, and gradual intraluminal narrowing reduces coronary flow reserve over weeks to months, eventually resulting in ischemia at lower thresholds of demand. Whereas mechanism B, plaque disruption, thin cap fibroethyroma with high macrophage density, acute myocardial rupture and endothelial erosion, sudden exposure of the thrombogenic lipid core contents to circulating blood, triggering an immediate, unpredictable coagulation cascade. This is about the thin cap fellow. So in a given patient, can I say whether he has got a thick cap fibroethyroma or a vulnerable fibroethyroma? This is non-vulnerable, this is vulnerable. Can I say, yeah, you have biomarkers in the blood to say whether a particular patient has got a thick capped non-vulnerable plaque or a thin capped vulnerable plaque. And also there are interventions to convert a vulnerable fellow into non-vulnerable fellow, to protect a vulnerable plaque from rupture and convert it into a non-vulnerable. That is the teaching. We'll come to that in the next class. But now, fibrin-rich red thrombus, platelet-rich white thrombus. If platelets are dominant in that thrombus, it is called white clot. Whereas fibrin-rich red thrombus is fibrin and red cells are entangled and the cross-linked fibrin matrix entrapping the erythrocytes, associated with predictable, slowly worsening ischemic threshold. Here forms an area of high shear stress over acutely ruptured plaques and rapid progression of activated platelets and partially occlusive but highly unstable. This can at any moment progress onto total occlusion, STEMI. Scenarios, two different scenarios. Now, I put this on a matrix here. Clinical circumstances on this axis, acuity of presentation or severity on this axis. Okay, a person may have extra cardiac condition like anemia, infection, hypoxia, which is non-cardiac condition, clinical circumstance, and severe new onset accelerated crescendo angina, he may present, he comes into this box. Treatment is not thrombolysis or angioplasty or cath lab. Treatment is the underlying condition. Another fellow is there. Intrinsic coronary plaques are there. Plaque rupture and progression. He had a vulnerable plaque. He ruptured and he has got a progressive angina. And then immediately he is a candidate to revascularization. Now, post-infarction person, a person who had infarction already, he has got unstable angina within the first 2 weeks, whether he is class 1 or class 2 or class 3, depending on the angina, we have to see. And if he is having class 3 angina and he is C-grade patient, immediately requires reperfusion therapy. Now, crescendo angina. Crescendo means increasing. That is progressive angina, rest angina. You have to differentiate. Pathophysiology, crescendo angina, progressive organic and luminal narrowing due to a stable plaque. Whereas rest angina, acute rupture of a vulnerable thin cap plaque. Plaque type, thin and stable fibrous cap. Here in rest angina, thin cap fibroethyroma, TCFE. Then thrombus profile, fibrin-rich red clot. Here it is platelet-rich white thrombus. I showed you in the previous slide. Clinical timeline, symptoms worsen over days to weeks. Whereas in acute rupture, sudden onset at least within the 48 hours. Angiography, occlusion at the site of prior severe stenosis. That is the angiography. Here, occlusion at the site of previously mild CAD. Earlier, there was no CAD in the previous angiogram. Now it got occluded. Why? Because of the rupture. The prognostic threat, predictable mechanical obstruction here. This is unpredictable, high risk of acute STMI. An acute rupture can lead on to acute ST segment, fatal myocardial infarction. Crescent angina versus rest angina. Now, what is the history like? History remains paramount in recognizing the classic angina and angina equivalents. This term you must know. Angina and its equivalent, not chest pain, but equivalent to angina. What are they? What is classical presentation? Retrosternal pressure, tightness, radiation to the jaws and arm, dyspnea on exertion or at rest also, extreme fatigue, nausea and sweating. Out of these, some are anginal symptoms, some are angina equivalents. Retrosternal pressure, tightness of the chest, burning sensation, radiation to the jaw, neck, left shoulder, both arms, incomplete resolution with rest or sublingual nitroglycerin. Why is it important? Stable angina will also have the same thing, but he immediately recovers once he takes rest or uses sublingual sorbitrate, nitroglycerin. Okay, a chest pain which is there in this description, not responding to sublingual nitroglycerin or rest is not a classical angina or stable angina. So this is an unstable angina. What are angina equivalents? Unexplained dyspnea, extreme fatigue, nausea, vomiting, severe sweating, diaphoresis, isolated jaw and back pain. Several patients have come with these symptoms. We diagnosed acute coronary syndrome, unstable angina, progressing on to NSTE. High-risk demographics. Who are the people who present with anginal equivalents? Women, diabetics, elderly, CKD patients. Women, diabetic patients, elderly patient, CKD patient, they will not have classical chest pain described above. They will have angina equivalents mostly. What is the clinical pearl? Any unexplained exertional dyspnea in a diabetic patient must be evaluated as an angina equivalent. A diabetic fellow is there is exertional dyspnea. Don't ignore. Maybe కొంచెం ఎక్కువ తిని ఉంటావు, యూ వుడ్ హావ్ టేకెన్ ఎ లిటిల్ మోర్ ఫుడ్, అందుకే ఆయాసంగా పడుకుంటే పొద్దున్న పడుకుంటాడు అంతే, మరి లేవడం చేత. అర్థం ఏంటి? ఎనీ డయాబెటిక్ పర్సన్ with above and angina equivalent symptoms must not be brushed away and ignored. He must be evaluated. Now, what are the physical examination findings which will be helpful to me? Symptoms I have seen in the previous slide. What are the physical examination findings? Elevated JVP, hypotension. These tell me that he is ending in a right ventricular failure and right ventricular ischemia, impending cardiogenic shock. Look at the JVP. JVP elevated, blood pressure is low, left to right ventricular infarction, impending cardiogenic shock. New apical systolic murmur. Earlier when you saw him, there is no murmur. Now a new murmur has developed at the apex. That is papillary muscle dysfunction. Or he has S3 gallop, the third heart sound, S3 gallop. S3 gallop with pulmonary rails tells me he has got elevated LVDEP. That is the elevated end diastolic pressure of the left ventricle and pulmonary congestion. S3 gallop is pulmonary congestion and left ventricular failure. Whereas dyskinetic apex, S4 gallop are there, points to the acute diastolic dysfunction. Ischemic ventricle becomes stiff and non-compliant. And except for the atrial kick, there is no ventricular kick. All that is going, atria only are contracting, ventricle is sleeping. Now, four important things: elevated GVP, hypotension, right ventricular ischemia, cardiogenic. Apical systolic murmur, new onset apical systolic murmur, transient papillary muscle dysfunction. S3 gallop, pulmonary rails, LV dysfunction, left ventricular and diastolic pressure, and pulmonary congestion. S4 gallop, dyskinetic epic, tells me it is a diastolic dysfunction, acute diastolic dysfunction, and non-compliance of the ventricle. Now, I have seen symptoms. I have told you about the signs that you should look for. And now, dynamic ECG repolarization abnormality are the hallmark of unstable ischemia. What are the things? The first one is the normal PQRST wave. The second graph here, you see there is symmetric cup-shaped inversion with not much of ST segment depression. This is the second presentation. The third one is T waves are not inverted. There is an upsloping or downward depression of the ST segment, classical of unstable angina. ST segment depression, horizontal or downsloping depression of more than 0.5 millimeters. It should be not in only one lead, two contiguous leads, highly specific for subendocardial ischemia. T wave inversion, deep symmetric T wave cup-shaped inversion, more than 1 millimeter in depth, contiguous leads with prominent R waves. It's also ischemic signature. Hyperacute T waves, we have seen in the previous class. Early transient peak T waves, where the base will be wider, unlike in hyperkalemia, where the base of the T wave will be narrow. What is the diagnostic trap? 50% of the patients with unstable angina may present with a normal ECG. A normal ECG never excludes the diagnosis of ischemic heart disease and unstable angina. Whatever changes we have described, they occur only in 50% of unstable angina. Remaining 50% of patients, ECG is normal. Now, patient presentation, serial HS troponin we have done, and contiguous telemetry, serial ECGs are a monitoring you have done, 15-30 minutes you have watched, risk stratification engine, you have to use TIMI score and Grace score. I will show you in the subsequent slide. What is TIMI score? What is Grace score? Already I told you, again we will revise. Now, a patient has got clinical presentation suggestive of an ischemic heart disease, unstable angina. We also considered angina equivalent, particularly in women, diabetic, elderly, CKD patient. He has got one of those symptoms. Look at ECG, 50% of them will show some abnormality, 50% will not show any abnormality. I cannot discharge the patient simply because the ECG is normal. I did a HS troponin. It may be elevated. If it is elevated, we have to see 1 hour and push him towards NSTMI, STM. It may not be elevated. ECG is normal. Serial troponins are normal. Patient has symptoms lasting for more than half an hour. And I have serial ECGs, serial troponins I am seeing. Then not only you do serial ECG and serial HS troponin 0 over 1 hour, you must do the TIMI score and Grace score also. Then what do I know by doing the score? You will be classifying the patient early invasive, conservative. If the TIMI score is more than 3 or the Grace more than 140, this patient will benefit from early angiography and intervention. The other way around, TIMI score is 2 or less number, Grace score is less than 140, then he will not benefit from taking him to the cath lab. Understood? Patient's presentation, clinical features, ECG changes, HS troponin, risk stratification, TIMI score, Grace score. Patient has symptoms suggestive of ischemic heart disease, looks like unstable angina, ECG is normal or has some changes, HS troponin mildly elevated or normal, serial ECGs we are following, and also we are doing TIMI score and Grace. TIMI 0, 0, 1, 2. conservative therapy. Grace less than 140, conservative therapy. TIMI score 3, 4, 5, 6, 7, 3 and above, or grace more than 140, you must go to the cath lab for early angiography. Here early means not within 1 hour, not within 2 hours, no emergency. The next 24 hours here. Whereas in STMI, time is muscle. Here muscle is not totally lost here. Now, previous days, we used to use troponins. These troponins, if they raise to that much level only, we used to detect them in the blood. This is called the troponin limit, standard limit. Now we are using high sensitive troponin. Even at this level, we will be able to detect. That is why we are insisting you should go for high sensitivity troponin and not the regular troponin. Today we are in an era of high sensitivity troponin. Don't use regular troponin anymore. A patient who's troponin negative earlier, that means he is somewhere here, he will be called negative by earlier test, but high sensitive test will be positive. A patient who was negative earlier and then 2010 is now HST troponin positive and he becomes unSTEMI. The classification totally changes. So don't use the standard troponin era historical versus high sensitivity troponin era modern. Here, diagnostic bucket, large number of population were included as unstable because we don't have a HS high sensitivity assay. Required 12 hours for the diagnosis. This troponin used to raise to that level 6 to 12 hours and it failed to detect microinfarctions, often delayed the treatment for negative markers and only clopidogrel was used regularly for the pain. I have aspirin clopidogrel combination and discharge I was doing earlier. Now I should not do that. High sensitivity era, shrinking the bucket into small number of people, growing unSTEMI because of the high sensitivity is positive. Rule in or rule out within 1 to 2 hours. Don't wait for 6 to 12 hours. Accurately identifies the submyocardial subclinical myonecrosis. Immediate early invasive treatment is triggered. And I don't use clopidogrel now. I use ticagrelor or prasugrel preferred when we confirm unSTEMI. That is why don't depend on conventional troponin. Do high sensitivity troponin. Is there anything called unstable angina? No. See, when the troponin is normal, ECG is normal, chest pain is there, why do you call him as ischemic heart disease? Because ECG is normal and then chest pain is, the ECG is normal, troponin is normal, high sensitivity. Yeah, you still have unstable angina. There is a big group of people who have ST segment elevation infarction, non-ST segment elevation infarction, who have ECG changes of those, and also delta troponin is very elevated. There are different groups. There is another group who don't have the HS troponin positive or ECG is normal, whose symptoms have disappeared. These are the stable angina fellows who are cured with nitroglycerin or rested. That is also understood. But there is a group of patients who are mixed and they are the unstable angina. The modern reality is, yes, unstable angina exists. But this number has shrunken because of the classification using the HS troponin. Without HS troponin, most of them will be in this gray zone. Conclusion, we are returning to a binary understanding of ischemic heart disease, stable angina versus myocardial infarction. Stable angina this side, myocardial infarction this side. In between is the unstable angina. Now, part 1, I am summarizing. Pathophysiology. What is the pathophysiology? Crescendo angina, progressive atherosclerosis, red thrombus, rest angina, not relieved by nitroglycerin, not relieved by rest, versus acute plaque rupture, white thrombus, both demand aggressive antiplatelet and anticoagulant. ECG vector, that means dynamic ST depression or T inversion, highly specific for ischemia. Up to 50% of people may not have ECG changes. Treat the patient history and not the paper. You understand? read the patient's history and not the ECG paper. ECG paper may be normal, no changes, but patient has symptoms, treat. Paradigm has shifted. High sensitivity troponin has fundamentally redrawn the AC spectrum. Unstable angina no longer is a big basket of broad category. It is shrinking. Diagnosis of exclusion. Let TIMI and Gray's risk stratification should decide the drive and not the biomarker alone in unstable angina. Now, what is TIMI? What is Gray's? How to apply them? What is heart score? This is from bedside ready cognitive framework based on 2025 ACC guidelines and 2023 ESC guidelines, second part. Now, you see, I have a patient with ischemic risk. He is on this side of the path. How is ischemic risk? Myocardial infarction, heart failure, ventricular arrhythmias, cardiac arrest. Now, HSTA troponin era, high sensitivity troponin SS, many previously troponin negatives, which were called as unstable angina, now they have become NSTMI patients because of micronecrosis. Then, you also, what is the goal? The goal is tailored target triage mechanism, mapping quantitative risk directly to the cath lab. Which fellow should go to the cath lab? Which fellow requires observation? Which fellow can go home? Is the triage. Now, the procedural and bleeding risks are also compounding nowadays. Most of the patients are already on aspirin or some double platelets also, and there is associated iatrogenic bleeding risks are also there. By going into the cath lab and putting in the catheter, you may puncture the coronary vessel and produce a bleed or a hematoma in the coronary circuit. And that is called HBR, high bleeding risk category. I should not unnecessarily employ catheterization. I should not stop catheterization when it is required. That decision is crucial. Whether he should go to the cath lab or whether he should be on optimal medical treatment and sent home. It's very imperative for me to decide because of the risk of procedural risks and bleeding risks are there. Now, what is the clinical mandate? Accurate stratification prevents the undertreatment of patients with high risk, overtreatment of patients who are low risk. What I should do as a clinician, I should not overtreat a patient with a little low risk. I should not go on doing angiographies, plastics unnecessarily. At the same time, I should not leave the high-risk fellows without doing proper coronary intervention and put them to lifetime danger or life danger. That is the balance. That is why the balance here. Now, we have a back to heart score. What is heart score? History. Only three way. Very highly probable 2, moderately okay 1, and 0. History not so. ECG significant, biomedia non-specific, normal. Significant, non-specific, normal. Significant 2 points, non-specific 1 point, normal 0 point. Age more than 65 2 points, 45 to 64 1 point, less than 45 0 point. Risk factors more than 3 risk factors 2 points, and 1 to 2 risk factors 1 point, no risk factors at all, none. That is 0. Troponin more than 3 times upper normal limit 2 points, 1 to 3 times upper normal limit 1 point, less than or equal to normal limit 0 point. So, H, history, ECG, age, or risk factor, T troponin, each one have 0, 1, 2, 3. So, maximum how many can be there? 5 variables are there. 2 is the upper limit, upper score in each, 5 into 2, 10. What is the lowest score? 0 into 5, 0. So, the score can be 0 to 10. Now, I did the score, and if the score is 0, 1, 2, or 3, discharge. Anybody between 3, 4, 5, 6, 7, 5, 5, 6, admit and observe. 7, 8, 9, 10, take the cath. This is the triage using the heart score. You should never forget to use the heart score the moment you see a patient in the ED of undifferentiated chest pain. Anything less than 3 So he is fit for discharge, non-cardiac pain. You can evaluate the pain, cause of the pain separately. Somebody between 4 and 7, he should be admitted and observed. 7 and above, they must be evaluated and given the benefit of revascularization. This is first you applied heart score, then two more are the TIMI score and GRACE score. I'll show you. What is TIMI score? TIMI score is 7 variables are there. Age more than 65, more than 3 risk factors, prior coronary stenosis of more than 50% in the previous angiogram, ST segment deviation on presentation, more than 2 anginal events in the prior 24 hours, aspirin already using for the prior to 7 days. He is already on aspirin, in spite of it, he got the symptoms. Elevated serum cardiac markers, elevated HS troponin. 7 variables, very simple. Each one 1 point. Age more than 65, 1 point. More than 3 risk factors, 1 point. Primary coronary stenosis, more than 50%, 1 point. ST segment deviation presentation, 1 point. More than 2 anginal events, 1 point. Aspirin already under use, 1 point. Elevated cardiac biomarkers, 1 point. Suppose they are not there, 0 point. So what will be the maximum score? 0 to 7. If the score of TIMI is 1 and 2, you are very safe. That is the cutoff point. How do I know that? Tactic TIMI trial. Tactics trial. There's one trial called the Tactics TIMI trial that has shown all patients with TIMI score of 1 and 2 can be fairly managed outpatient and they can be discharged. Because the event rate, death rates, myocardial infarction, and ischemia are minimal in them. Over next 10-year period, 4.7 to 8.3% in 10-year period. This is the risk estimate. So you are very safe to discharge. If the TIMI score is more than 2, that means 3, 4, 5, or 6 and 7. 13.2, 19.9, 26.2, and 40.9% chances of critical event. What are the events? Death, myocardial infarction, or ischemia. So my TIMI score estimate is essential in every patient after doing the heart score. Do heart score, then do the TIMI score. Now, the third, this is not a simple 1, 2, 3 numbers here. These are all weighted scores. So you have to use this GRACE score. Input variables are age, heart rate, systolic BP, creatinine, KLIP class 2, cardiac arrest on admission, ST segment deviation, elevated biomarkers. Each one is given a weight. So how do I calculate? You can't put any number and write it here. You put these variables in the medical calculator. Age, heart rate, systolic BP, creatinine, KLIP class, cardiac arrest, yes, no, ST segment deviation, yes, no, elevated biomarkers, yes, no. You put it and it will give a summary score. What is the dial? Anything less than 140 is very safe. More than 140, it is high risk threshold. You must go to cath lab. How do I know that? Endorsed by 2023 European Society, 2025 American Cardiology Society guideline. Now what has come? Heart score, TIMI score, and GRACE score. How to work out? I'll show you later. Now, TIMI score, GRACE score. TIMI is, how do you know? Because this study, TIMI 11B Essence trials have shown that. GRACE score, GRACE Global Registry. Complexity, 7-point binary checklist. This is a complex nomogram. You require a digital calculator for the GRACE score. Primary strength, bedside speed and rapid memorization, and superior predictive accuracy and continuous risk scaling. Endpoints, 14-day death, myocardial infarction, urgent revascularization. In hospital and 6-month mortality. Guideline stands historical foundation for TIMI and preferred by the 2025 guideline. Synthesis, while TIMI offers bedside triage, GRACE provides validated precision by modern ACC guidelines to mandate less than 24 hours catheterization. Okay. Now, my patient can have 3 options. Code red. immediate invasive strategy. IIS, immediate invasive strategy. He must go to the cath lab within 2 hours and then get it done. In this cohort, unstable angina is treated with a logistic urgency of an STMI. We are now treating unstable angina also as though it is already STMI, in spite of no direct evidence. If we have direct evidence, anyway, he will qualify for it. What are the variables which make me treat this like STMI and put him under immediate revascularization within 2 hours? Number one, hemodynamic instability, cardiogenic shock, refractory angina despite maximal medical therapy like beta blockers, nitroglycerin, whatever you want to take, life-threatening arrhythmia, cardiac arrest on presentation, mechanical complications like new apical systolic murmur, papillary rupture and ventricular septal defect, mitral regurgitation, VSD, or free wall rupture. Acute heart failure definitively linked to ischemia. If you have any one of these 5 variables, he should be treated on par with STMI, ST segment elevation myocardial infarction. Time is muzzle, less than 2 hours, he must be reperfused. This is code red. What are they? Hemodynamic instability, cardiogenic shock, refractory angina despite maximal medical therapy, life-threatening arrhythmias, cardiac arrest, mechanical complications like apical systolic murmur, mitral regurgitation, acute heart failure definitively linked to the ischemia. Now, amber pathway. Amber pathway means indicated for stabilized patients exhibiting still high-risk features. What are they? Gray score is more than 140. Dynamic ST segment and T wave changes, they are increasing. Symptomatic patient or a silent patient. Rise and fall in the cardiac biomarkers. So biomarkers are increasing and then ST segment T wave changes are progressing. Ray score is more than 140. You must go to reperfusion, not within 2 hours, but within 24 hours. This is called the amber pathway. Early percutaneous coronary intervention within the first 24-hour window is associated with significantly lower mortality and major adverse cardiovascular events. So what is the outcome here? Mortality benefit, MACE benefit. If you do it within 24 hours. And compared to do it after 1 week or 1 year, these when you do the procedure within 24 hours, they get benefit from major acute coronary events and also mortality benefit. Who are these people in the amber pathway? Gray score more than 140, dynamic ST segment and T wave changes. Patient may be symptomatic, may be silent, rise and fall of the biomarkers. This is the second category. Then the green pathway. Sorry, I had to discuss a cardiac patient who is requiring a stress echocardiograph tomorrow for some reason. So anyway, the green path, the red pathway, red core, amber pathway, and the green signal. Well, who is the person who is in green signal? No recurrent chest pain, symptoms have vanished after 15 minutes, 1 hour, half an hour after your medical management. There are no dynamic ECG changes. ECG changes also settled. Negative serial high sensitivity. 3 hours I observed no increase in the troponin. Gray score is less than 109. TIMI score is either 0, 1 or 2. They are safe, we can discharge him. But non-invasive testing we have to conduct because he had say chest symptoms, anginal symptoms, or angina equivalents. Safe discharge and medical management is one option. Non-invasive testing is another option. Okay. Now, what is the evidence-based restraint for you here? Tactics TIMI data. Routine early catheterization does not confer any extra benefit for this fellow. Don't put him into the cath lab now. Subjecting these patients to routine angiography unnecessarily exposes them to procedural risk and bleeding risk, iatrogenic harm. For these 2 reasons, they are not candidates to go into the cath lab. However, I will not leave them like that. I will do non-invasive testing. What is the non-invasive testing? Non-invasive functional testing. This is where exactly our patient today. We are doing this test for him. Functional tomorrow. Functional testing stress echo is what we are thinking. Why? This is high specificity. That means if it is positive, the disease is certain. High sensitivity. If it is negative, it rules out the disease. These cannot confirm the disease. This can confirm the disease. High specificity cannot rule out the disease. High sensitivity cannot confirm the disease. Best thing is you have one test from this side, one test from this side. One is called the nuclear perfusion testing. The other is the stress echo. High sensitivity test used to rule out disease. High specificity test is there to confirm if the disease is there. Both the modalities together. Anatomical testing is again doing coronary. I don't prefer this because this patient, what we are discussing with him. Now, for this patient, non-invasive functional testing, for the green channel fellow, whom I have not done the angiogram, I'm going to do the functional testing. What are the functional testing? Stress echo to confirm, functional testing to exclude, nuclear perfusion. This is called myocardial perfusion index. MPI, myocardial perfusion index, will be calculated using a nuclear method. Suffice for you to know that there are two tests. One is called the nuclear perfusion, the other is called the stress echo. One has got a value of high sensitivity, it excludes the disease. Other one is high specificity, it confirms the disease. You may not know what is sensitivity and specificity right now, but I will tell you later on what is sensitivity and what is specificity. Now, I have to manage this fellow. The investigations are over, diagnosis is over, heart score is applied, and then the TIMI score is applied, and then the other score, gray score is applied. Then I have excluded from cath lab and did some investigations required for the non-invasive testing. Now how to manage it? How to manage? Oxygen therapy. Is everyone requires oxygen? No. If the PO2 is less than 90, only you give oxygen. Why restrict? Why not give to everyone? If you give to everyone, there is what is called a hyperoxic coronary vasoconstriction. And that paradoxically worsens the ischemia. Hyperoxic coronary vasoconstriction is a known phenomenon which increases and worsens the ischemia. You see SpO2, if SpO2 is less than 90 only, give this mask oxygen or nasal oxygen. No intubation. Nitrates. How do nitrates act? By potent venodilatation, and venodilatation reduces the preload and thereby decreases the ventricular wall stress and increases the endocardial perfusion. This is the mechanism. Nitrate, venodilatation, preload reduction, decreased ventricular wall stress, improved subendocardial perfusion, symptom reduction. Strict contraindications for nitrates. Patients who are already on PDE5 inhibitors, like Viagra type of drug, PDE5 inhibitors they are taking, you should not give nitrates. Why? Precipitate fall of blood pressure and hypotension can occur. Or patients who have got right ventricular ischemia, you are not supposed to give nitrates. Nitrates, two contraindications. One, PDE5 inhibitor treatment, people who are on that, you should not give, and right ventricular infarction. So what is my management starting? Oxygen, nitrates. Oxygen for whom? Nitrates for whom not, I have told. Now, beta blockers. Everybody, unless contraindicated, must get beta blocker. Why? Because beta blockers lower heart rate, systemic blood pressure is reduced, myocardial contractility is decreased, directly reducing the ventricular work and wall tension. But there could be some contraindications for beta blocker. If there is an acute heart failure, I should not give. If there is a very active hyperreactive airway disease, I should not give. Then what I should do? I should give verapamil or diltiazem, non-dihydropyrin. Or dihydropyrin, amlodipine can be used in peringimental angina or variant angina presentation. What am I looking at? Heart rate reduction, contractility reduction, BP control. All three have. This will increase decrease the myocardial oxygen demand and improve the symptoms. So what are my treatments? Myocardial oxygen supply, And then demand reduction, supply increase. Increase the supply, decrease the demand. Increase the supply, oxygen, nitrates. Decrease the demand, beta blockers, calcium channel blockers. Is there any other drug I can give? Yeah, you have one more. What is called the ranolazine. Ranolazine is a late sodium channel inhibitor. If the late sodium current is inhibited, calcium influx into the myocardial cell is reduced. Once the calcium accumulation is reduced, it improves the diastolic relaxation of the ventricle. And once the diastolic ventricle relaxes more, it receives more blood and then becomes mitrovascular perfusion will improve. This is the hemodynamic advantage. There is Merlin TIMI 36 trial is there. It has conclusively proved ranolazine is beneficial. It has demonstrated a significant reduction in recurrent ischemia patients with chronic angina post-TACS, serving as a critical adjunct when HRBP are already maximally lowered. Again repeating, reduce the oxygen, increase the oxygen supply, oxygen therapy, nitrates with respective contraindications, and then decrease the heart rate, contractility, and blood pressure. How? By beta blocker. If contraindicated, calcium channel blockers. Any other drug? Ranolazine. Add this. Now, there are some special populations. Risk stratification, women, high prevalence of MINOCA. What is MINOCA? Myocardial infarction with non-obstructive coronary arteries. You do coronary angiogram, normal, but they have myocardial ischemia. This is called MINOCA, myocardial infarction with non-obstructive coronary arteries. Why? Because of the what is called the microvascular perfusion is different. Macrovessels, the epicardial vessels are normal, but microvascular perfusion is defective. Symptoms are they have atypical fatigue, dyspnea, and they don't have a crushing chest pain because epicardial vessel is not involved. This is called a MINOCA. Second one is chronic kidney disease. Chronically altered HST troponin baselines. Baseline itself, troponins are raised not because the heart is damaged, but because of the chronic disease. Higher baseline risk for bleeding complications. These fellows have more bleeding complications. And so contrast-induced nephropathy, when CKD is 4 or 5, you should not do angiography because you inject the contrast. This contrast worsens the CKD. This is our patient. Tomorrow whom we are going to. Is already a CKD patient. We don't want to do angiogram. That's why we are using the non-invasive. Older adults. Risk stratification must balance physiological frailty, height and bleeding risk against the undeniable ischemic benefit. In adults, there is an ischemic benefit you are giving. There is also frailty and bleeding risk. You have to balance both of them. Now, we are now closing now. Part 2 synthesis, we are coming. Suspected ACS, TIMI gray score calculation, red line, shock refractory instability within 2 hours, amber, gray score more than 140, dynamic ECG changes, and then put him on the amber line, and green line, low risk, negative biomarkers, anti-ischemic shield, that is oxygen less than 90, nitrates, beta blockers, and ranolazine. Closing takeaway, unstable angina management in 2025 is an exercise in precision logistics. Quantify the risk mathematically using the gray score, TIMI score, and heart score. Time the catheterization appropriately, less than 2 hours, within 24 hours, or you can do it at a later stage using the non-invasive methodology. Relentless balance between the myocardial supply and the demand. Now, very quickly, you should balance the risk of thrombosis, risk of bleeding. Both you have to assess. How do I assess risk of thrombosis? Gray score, TIMI score, dynamic ST changes. But how do I assess the bleeding risk? There are a criteria of bleeding risk assessment, and you have to use ARC, HBR criteria, the Crusade score. There is another score called the Crusade score. If you apply that, the bleeding risk will be stratified. What is the drug I have to use? Aspirin. Why? COX-1 inhibitor. This is the cyclooxygenase 1 inhibitor. Irreversible inhibition of cyclooxygenase 1. Thromboxane A2 is not formed. When thromboxane A2 production is halted, then there will be a no platelet adhesion, activation, and activation. It is an antiplatelet. How much I give? 165 to 325 milligrams. or 300 milligrams rectally also you can give. Better to give entry-coated aspirin. Maintenance 75 to 100 milligrams. These are based on the guideline sheet. Now, what are the other agents for the dual antiplatelet therapy? I have clopidogrel in the bottom line. Clopidogrel 300, 600 milligrams loading dose, 75 milligrams is continuation dose, irreversible binding, it is a prodrug. Now, the contraindication is hepatic impairment and reserved for high bleeding risk patient, recurrent oral anticoagulation patient, or when the potent agents are not available in your pharmacy or in your town. Ticagrelor, reserved reversible shield, 180 milligrams loading, 90 milligrams BID. First line for NSTE, ACS, regardless of the initial invasive or conservative. So active pathological bleeding and history of intracranial hemorrhage are contraindicated. Prasugrel, I can give 60 milligrams loading, 10 milligrams daily. It is very irreversible and then ultra rapid in its action, preferred by the guidelines. Absolute ban in patients with stroke and TIE. Which is the companion antiplatelet agent to aspirin? Either clopidogrel or ticagrelor or prasugrel. Depends upon the type of patient as listed in the table. Now, how long I should continue the double antiplatelet? High bleeding risk, that's all. 3 months you stop. Don't go beyond 3 months. 1 to 3 months only. Truncate and only continue one platelet. Suppose somebody is having high no bleeding risk but high ischemic risk. Continue beyond 1 year, both the drugs. Suppose in between and then standard risk, give for 1 year and reassess and if necessary, continue. How long I should give the DAPT, double antiplatelet agent, high bleeding risk, 1 to 3 months. No bleeding risk, high ischemic risk, more than 1 year. Like left main disease or recurrent ACS and all. People who are intermediary category, 1 year you give double antiplatelet and then reassess and decide whether you continue. Okay. There is one more drug which we know, that is this is a intravenous G2B3A inhibitors, glycoprotein 2B3A inhibitors. These are also final common pathway platelet activity blockers. 3 drugs are there: eptifibatide, tirofiban, epsiximab. Okay. To which patient I use? This is the ultimate blockade of the final common pathway. Not everybody is required to take 2B3A inhibitor. Strictly reserved as a bailout therapy for massive angiographic thrombosis. If you do an angiography, massive thrombus is there. Already you have used aspirin, you have used the P2Y inhibitor like clopidogrel or prasugrel or ticagrelor. The third antiplatelet drug, G2B3A, is required for massive thrombus burden. And there is one drug also called the cangrelor. Not only glycoprotein 2B3 inhibitor, there is a cangrelor is another type of antiplatelet agent. And ultra rapid onset, within minutes it starts acting. Indication, ideal bridge to start the long-acting drugs like clopidogrel and other things. Cangrelor, not for everyone. And then anticoagulation, heparin. It works on thrombin 2A and factor 10A inhibitor, whereas enoxaparin works only on the 10A. So, never use together. Don't use conventional heparin and enoxaparin because trials have shown high bleeding risk in them. What is preferred? Unfractionated heparin. How much? 5,000 units directly you give in IV. Whereas enoxaparin, depending on the age and renal function, 0.3 or 0.2 syringe you take and give it. That is once or twice a day subcutaneous. Now, conservative strategy, interventional exceptions. Fondaparinux is a new drug. It's a conservative darling and systemic pentasaccharide, synthetic pentasaccharide, pure factor 10A inhibitors. Guideline stance is conservative therapy. You can use fondaparinux in cath lab. If you want to use fondaparinux, you must give unfractionated heparin before putting the catheter. Then, interventional exceptions, biliverdin. This is a thrombin alternative. It is a direct antithrombin inhibitor, biliverdin. Vivalardin and fondaparinux are special drugs to be used with discretion. Now, what is the triage? Use the syntax score. What is syntax score? I showed you last time. This syntax score tells me whether he should go for PCI or he should go for bypass. Depending on the syntax score, if it is more than 22, you go for bypass. If it is less than 22, you go for primary coronary intervention. Now, vasospastic angina, pringimental angina. How do I manage? Calcium channel blockers, long-acting nitrates, beta blockers are contraindicated. In pringimental angina, in regular angina, beta blockers are very important treatment. In pringimental angina, I should not use beta blockers. Nitrates also may not help very much. What is the drug I use? Calcium channel blockers are very helpful. Nitrates also, long-acting nitrate you can add. But beta blockers should not be given and all can exacerbate spasm, alpha receptors unopposed. Okay, coronary microvascular angina. I told you, this is a very common in women, and subendothelial dysfunction will be there. Aggressive risk factor management. Ranolazine is one drug which helps the microvascular dysfunction. How about my lipids? You have to see that the lipids, very good rosuvastatin, 20-40 milligrams of rosuvastatin. And you can use ezetimibe as a companion drug. If not still controlled, you have to use PCSK9 inhibitors like, elorecumab or evolocumab. You have to use the monoclonal drugs for the people who don't respond. What is my target cholesterol level? Less than 55. If a patient has got ischemic heart disease of this nature, unstable angina or NSTMI or STMI, the cholesterol level is not 100. LDL cholesterol should be less than 55. Can I achieve with rosuvastatin? May not be. Add ezetimibe, a cholesterol absorption drug inhibitor. If that is also not possible, use PCSK inhibitor like evolocumab. This is about the lipid management. Then along with beta blockers, are there any other companion drugs for blood pressure and cardiac protection? Yes, inhibitors, ARBs, ARNIs you have to use. And mineralocorticoid receptor antagonists also can be used. And platelet and coagulation. Platelet pathway, Voyager paradigm, combine low dose aspirin and vascular dose of rivaroxaban. That is for the platelet pathway. Coagulation cascade also can be worked out. Synergistic dual pathway blockade, blocking the platelet pathway, blocking the coagulation pathway, platelet pathway with the aspirin, coagulation pathway with the rivaroxaban, a combination in cases of high ischemic risk patients continue to experience major adverse coronary events despite a maximal single pathway or antiplatelet therapy. If the patient is symptomatic, in spite of antiplatelet therapy, either single or double, then you can combine the coagulation pathway. So by adding rivaroxaban. Now, what is the role of colchicine, which was used earlier for some other indication? That colchicine is brought here. How is it useful? 0.5 milligrams daily. Colchicine is anti-inflammatory. The landmark trial is COLC, Colcott trial, and LODO COT trials have shown colchicine inhibits the interleukin 1B and interleukin 6, and C-reactive protein production is reduced, and they have a beneficial biological context. Now, zone 1, zone 2, zone 3, zone 4. Zone 1 acute presentation is stratification, TIMI grace, and aspirin clopidogrel anticoagulant fondaparinase. Risk 2, gray score more than 140, goes to the cath lab within 24 hours. Whereas within 2 hours for those STMI. Low risk, conservative strategy, stress testing. Then now you have got the tailored adapt. How long I will continue? Double antiplatelet, 1 to 3 months in high bleeding risk. More than 12 months for high ischemic risk. Standard, 12 months. Finally, discharge shield must have not only these drugs, you must have lipid management, neurohormonal blockade, beta blocker, ACE inhibitor, anti-inflammatory, colchicine, dual pathway consideration with the rivaroxaban. So with this completes the story of unstable angina.